Every single day, thousands of older adults walk into their doctor's office sharp, aware, and fully themselves, and walk out with a prescription that will quietly start stealing that from them. Not all at once, not in a way anyone notices right away. It happens slowly. A name here, an appointment there, a familiar street that suddenly feels unfamiliar. And everyone around them says the same thing. It's just getting older. But what if it isn't? What if the fog, the forgetfulness, the confusion is coming from something sitting on the bathroom shelf right now? I'm Dr. David Adey, and today we're going to talk about something I believe every adult over 50 needs to hear. 9 common medications that research is linking to real, measurable memory loss in older adults. Some of these are prescription drugs, some you can buy at any grocery store without a second thought. And most people taking them have absolutely no idea what they might be doing to the brain. We're going to go through all 9, and I want you to stay all the way through because number 3 is one that surprises almost everyone, and number 1 isn't even a single drug. It's something much more common and much more dangerous. Let's get into it. Before we dive in, I want to set something important straight. This video is not about scaring you away from your medications. It is not a message that says, throw everything out and go natural. That kind of thinking can genuinely harm people, and that is never what this channel is about. What this is about is information, awareness, the kind of conversation that happens far too rarely between patients and their doctors. Here's what the research tells us. As we get older, the brain changes. The chemical systems that help us learn, remember, and stay mentally sharp become more sensitive. A drug that a 35-year-old body handles without much trouble can hit a 70-year-old brain in a completely different way. And the medical community is increasingly recognizing this. There's even a formal list called the Beers criteria, published by the American Geriatric Society, that names medications considered high risk for older adults, specifically because of effects on cognition. Several of the drugs we're going to talk about today are on that list. So here is my goal for the next 30 minutes. Help you understand what these medications are, what they do inside the aging brain, what the research actually says, and what safer alternatives may exist so that you can have an informed, empowered conversation with your own doctor, because knowledge is protection. And the more you understand, the better advocate you become for your own health. All right, let's start the countdown. Number 9. Number 9 is a drug almost everyone has taken at some point in their life, diphenhydramine. You'd recognize it by one of its most famous brand names, Benadryl. It's the little pink pill that people reach for when allergies flare up, when a cold leaves them stuffed up and miserable, or when they just want to fall asleep a little faster. It costs a few dollars. No prescription needed. It's been around for decades. And most people assume that because it's sitting right there on the open shelf next to the vitamins and the cough drops, it must be pretty gentle. Inside the brain of an older adult, it is not gentle at all. Benadryl belongs to a class of drugs called anticholinergics. Now, that's a technical word, but the idea behind it is actually simple. These drugs block a brain chemical called acetylcholine. Acetylcholine is one of the most important chemical messengers in the nervous system. It plays a central role in forming new memories, staying focused and alert, and processing information. Think of it as the brain's internal post office. It delivers signals from one neuron to another so that learning and memory can actually take place. Here's the problem. As we age naturally, the brain already starts producing less acetylcholine. It becomes a more limited resource. So when a drug comes along and actively blocks what little is available, the impact is far heavier than it would be in a younger person. The area of the brain that takes the hit first is the hippocampus. That small, seahorse-shaped structure is where new memories are formed before they get stored long-term. When acetylcholine gets blocked there regularly, the brain struggles to do one of its most essential jobs. A 2023 paper published in the Journal of Geriatric Cognitive Health followed older adults who used anticholinergic drugs like diphenhydramine on a regular basis and found a 54% higher risk of developing dementia compared to those who didn't use them. More than half again the normal risk, from something millions of people treat as harmless. Now here's what makes this especially tricky. Many people who take Benadryl for sleep or allergies don't even realize that what they're taking is diphenhydramine. It hides under brand names like Zizquil, Unisom sleep tabs, Tylenol PM, NyQuil, and dozens of others. Anything labeled nighttime, PM, or allergy relief is worth flipping over to read the active ingredients. What can you do about this? If you take it for allergies, there are newer generation antihistamines like loratadine, sold as Claritin, or cetirizine, sold as Zyrtec, that do not cross into the brain the same way Benadryl does. They're considered far safer for long-term cognitive health. If you take it for sleep, that's a conversation worth having with your doctor. There are gentler options, and the right one depends on why sleep is a problem in the first place. And as always, please do not stop any medication suddenly without talking to your healthcare provider first. The goal is to make changes safely, with guidance. That's number 9. And already you can see the pattern we're going to keep coming back to. A drug that seems harmless, a brain chemical that quietly gets blocked, and an impact that builds up over time without anyone connecting the dots. Let's move to number 8. Number 8 is a class of drug prescribed for one of the most common complaints in medicine: acid reflux and heartburn, proton pump inhibitors or PPIs. The most recognizable names are omeprazole, sold as Prilosec, and esomeprazole, sold as Nexium. These work by dramatically reducing the amount of acid your stomach produces, and they're genuinely effective at what they do. The problem is that people often start them for a short-term issue and end up on them for years, sometimes decades, because the moment someone tries to stop, the symptoms come rushing back harder than before, and so the medication feels like the only thing keeping them comfortable. What almost no one hears about at the pharmacy counter is what happens in the brain over that same stretch of time. Your stomach needs acid, not just to break down food, but to extract critical nutrients from what you eat. One of the most important is vitamin B12. B12 is essential for protecting the insulation around your nerve fibers, for supporting brain function, and for keeping your neurological system operating cleanly. When you suppress stomach acid for long enough, B12 absorption drops. So do magnesium and calcium levels, 2 minerals your neurons depend on to fire properly and communicate with each other. Starve your brain of these over months and years, and you start to see confusion, memory lapses, and cognitive slowing that can look almost identical to the early stages of Alzheimer's disease, when the actual root cause is a nutritional deficiency your medication quietly created. But it doesn't stop at nutrient depletion. Research has also shown that PPIs may raise levels of a protein in the brain called amyloid beta. That's the same protein that accumulates in the brains of people with Alzheimer's disease. A 2016 study published in JAMA Neurology looked at more than 73,000 people aged 75 and older and found that regular PPI users had a 44% higher risk of developing dementia than those who weren't on them. 44%. That is not a small number. If you've been taking a PPI every single day and you haven't revisited that with your doctor recently, that conversation is worth having. For many people, a gentler class of medication called H2 blockers, like famotidine, sold as Pepcid, can manage symptoms with a much smaller impact on cognition. Dietary adjustments, smaller meals, elevating the head of the bed, and even a supplement called deglycyrrhizinated licorice, which helps coat and soothe the stomach lining, can reduce dependence on these drugs significantly. The goal is always the lowest effective dose for the shortest necessary time. Not a pill taken indefinitely out of habit. All right, number 7. Number 7 is one that gets prescribed for a very personal, often embarrassing problem, and because of that, it rarely gets questioned. Bladder medications, specifically a drug called oxybutynin, sold as Ditropan. Overactive bladder is an incredibly common issue among older adults. The sudden, urgent need to get to the bathroom, sometimes without much warning. It disrupts sleep. It shapes decisions about going out. It causes real anxiety. So when a doctor offers a pill that can calm things down and give people back some control over their day, most patients are relieved and grateful. But here is what oxybutynin is actually doing in the body. It works by blocking acetylcholine, the same brain chemical we talked about in number 9, the same memory messenger. And unlike some medications that stay mostly in the body's periphery, oxybutynin crosses easily into the brain. It settles right into the areas responsible for forming and holding on to memories. A 2019 study published in the British Medical Journal followed adults over 65 who had taken strong anticholinergic drugs, including oxybutynin, for more than a year. Their risk of developing dementia was 49% higher than those not taking them. And here is the part that I find deeply troubling. In most cases, patients were never warned. They were told the pill would help with the bladder. Nobody mentioned it might be affecting the brain at the same time. So when the forgetfulness crept in, when words started taking longer to find, when familiar conversations felt harder to follow, everyone assumed it was just age. The medication was never questioned. The important thing to know is that you do not have to choose between your bladder health and your brain health. There is a newer class of medication called beta-3 adrenergic agonists. The main one is mirabegron, sold as Mirbatric. It works through an entirely different pathway in the body and does not block acetylcholine at all. For most older adults, it provides comparable relief without the same cognitive risk. Pelvic floor physical therapy is another remarkably effective option that many people don't know about until they ask. Bladder training techniques can also make a significant difference. These are real alternatives worth discussing. If you or someone you care for is on oxybutynin and has noticed some mental cloudiness, memory slips, or difficulty concentrating, please don't brush that off. Bring it up with the prescribing doctor. There are other ways. Number 6. Number 6 may be the most surprising one on this list because it is one of the most widely prescribed drug classes in the entire world. Statins. Simvastatin, sold as Zocor. Atorvastatin, sold as Lipitor. Rosuvastatin, sold as Crestor. These medications lower LDL cholesterol and have been shown to significantly reduce the risk of heart attacks and strokes. They save lives. Millions of people benefit from them every single year. And I want to be very clear right up front. This is not an argument against statins. For many people, they are absolutely the right medication. The cardiovascular protection they provide is real and well documented. What I want to talk about is the part of the story that often doesn't make it into the conversation at the doctor's office. The brain is a fat-rich organ. Roughly 60% of its dry weight is fat, and cholesterol isn't just something that clogs arteries. It's also a key building block for myelin, the protective sheath that wraps around your nerve fibers and allows signals to travel quickly and efficiently from one neuron to the next. The brain uses cholesterol in ways that are essential to how it functions. Now, lower cholesterol dramatically, and you may be reducing the brain's access to a material it genuinely needs. Not all statins affect the brain equally. The ones most likely to cause cognitive side effects are the ones that cross the blood-brain barrier most readily. Simvastatin and atorvastatin in particular tend to penetrate brain tissue more easily than others like pravastatin or rosuvastatin. A 2023 study published in Frontiers in Aging Neuroscience found that adults over 70 who had been on statins for more than 3 years had a 26% higher rate of mild cognitive impairment, with a greater effect seen at higher doses. Patients on certain statins sometimes describe unsettling experiences, a familiar name that simply vanishes, a conversation that disappears as soon as it's over, a route they've driven for 20 years suddenly feeling uncertain. These are things worth reporting. The good news is that if you are on a statin and you are noticing cognitive changes, switching to a statin that doesn't cross into the brain as readily may be all that's needed to improve things. Pravastatin in particular is often cited as a more brain-friendly choice. But again, please don't make changes on your own. Work with your doctor to find the right balance. Protecting your heart and protecting your brain are not competing goals. With the right conversation, you can pursue both. We are about halfway through, and I want to pause for just a moment. If what you've heard so far has been useful, if it's made you think about a medication in a new way, or reminded you of someone you want to share this with, take a second to hit the like button right now. It genuinely helps this information reach more people who need to hear it. And in the comments, I'd love to know, how many medications do you take each day? And has a doctor ever reviewed them with your brain health specifically in mind? I read those comments, and they genuinely shape what I cover next on this channel. All right, we're moving into the top 5. These are the ones that concern me most. Number 5 is a group of medications that are incredibly widely prescribed and almost universally misunderstood in terms of their long-term effects. Benzodiazepines. Lorazepam, sold as Ativan. Diazepam, sold as Valium. Alprazolam, sold as Xanax. Clonazepam, sold as Klonopin. These drugs are prescribed primarily for anxiety and insomnia, 2 conditions that are extraordinarily common in older adults. They work by enhancing GABA, one of the brain's own calming signals, turning down the volume on an overactive, overstimulated nervous system. And when anxiety is acute, when panic is real, when sleep feels completely out of reach, the relief they provide can feel like a lifeline. The difficulty comes with time. A 2022 study published in the British Medical Journal tracked over 8,000 older adults for 6 years and found that those who used benzodiazepines for longer than 3 months had a 51% higher risk of Alzheimer's disease. The longer-acting drugs in this class were associated with even greater risk because they accumulate in fatty tissue and the brain is full of fat. What happens over the long term is essentially a slow and steady suppression of the brain's ability to adapt. It learns less readily. It stays in a somewhat sedated state, even when the medication was taken hours ago. People often describe a persistent flatness, a sense of moving through fog, a feeling that they're not quite fully themselves anymore. And leaving these medications behind is genuinely difficult, which is something I want to acknowledge with real compassion. If you've been taking a benzodiazepine for more than a few weeks, the brain has adapted to its presence. Stopping suddenly is not just uncomfortable, it can be dangerous. Withdrawal from these drugs must be done slowly, carefully, and with medical supervision. The taper is typically done over weeks to months, dropping the dose gradually, and during that process, gentler approaches for anxiety and sleep, like buspirone, cognitive behavioral therapy for insomnia, relaxation techniques, and certain lifestyle changes can help fill the gap that the medication leaves behind. If you've been on one of these for years, please know that talking to your doctor about a plan to eventually reduce or stop it is one of the most protective things you could do for your brain. Number 4 is a single medication prescribed for 3 completely different problems, which is part of why it ended up in so many medicine cabinets. Amitriptyline, sold as Elavil. It started as an antidepressant, but over time it found its way into prescriptions for nerve pain, for sleep trouble, and even for migraine prevention. It works on multiple symptoms at once, which made it seem incredibly versatile. What was often underemphasized is that amitriptyline is one of the most potent anticholinergic drugs still in common use today. It blocks acetylcholine aggressively, and taken consistently over months and years, that blockade accumulates. A major study published in JAMA Internal Medicine in 2015 followed more than 3,400 adults aged 65 and older over a 10-year period. Those who had the highest cumulative exposure to strong anticholinergic drugs, with amitriptyline among the top contributors, had a 54% greater likelihood of developing dementia. What makes this especially sobering is that many of these people were taking relatively low doses, a small nightly tablet for nerve pain or sleep. Nothing that seemed heavy, but taken night after night, year after year, the effect on the brain compounds quietly. The good news is that for most of the conditions amitriptyline treats, there are safer alternatives available today. Nerve pain can often be managed with duloxetine or gabapentin. Sleep can be improved with melatonin, good sleep hygiene, or much lower anticholinergic options. Depression can be treated with newer antidepressants that carry far less cognitive risk. If you or a family member is taking amitriptyline, especially for sleep or pain, it's worth having a specific conversation about this with a doctor soon. Number 3. This is the one I mentioned at the start of this video. Paroxetine, sold as Paxil. It belongs to a class of antidepressants called SSRIs, selective serotonin reuptake inhibitors, and SSRIs, as a general group, are considered far gentler on the brain than older antidepressants. But paroxetine is the exception within its own family. It is the one SSRI with significant anticholinergic activity built into its mechanism. That one detail separates it from others in the same class, like sertraline, sold as Zoloft, or escitalopram, sold as Lexapro, which do not carry the same anticholinergic burden. A large review published in Frontiers in Psychiatry in 2021 found that older adults taking paroxetine showed measurable declines in short-term memory, word recall, and attention within the first 12 months. They were 30% more likely to show early signs of cognitive impairment than seniors on other antidepressants. There's a painful irony in that. A drug given to stabilize mood and improve quality of life, over time quietly eroding the mental clarity the person was hoping to preserve. The American Geriatric Society specifically includes paroxetine on the Beers criteria list, the formal catalog of medications considered high risk for older adults. The recommendation is to avoid it in seniors when safer alternatives exist. If you are currently taking paroxetine, please do not stop it on your own. That can trigger difficult withdrawal effects. But do bring up the question at your next appointment: is there a safer option for me? The answer, for most older adults, is yes. Number 2 is the one that concerns me most in terms of how quietly it has spread into places it was never designed to be. Antipsychotics, quetiapine, sold as Seroquel, risperidone, sold as Risperdal, olanzapine, sold as Zyprexa. These are serious, powerful medications developed specifically for conditions like schizophrenia and bipolar disorder. They were not designed for general use in older adults, and yet they are now frequently prescribed off-label in that population, often for sleep difficulties, general restlessness, or the behavioral agitation that can accompany dementia. In some long-term care settings, they have been used because they keep agitated residents calmer and more manageable, not because they represent the safest or most appropriate treatment option. A 2022 study published in Lancet Healthy Longevity tracked more than 25,000 older adults and found that those placed on antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within a single year, even those who had shown no signs of dementia before the medication began. These drugs work by suppressing dopamine, a brain chemical tied not only to mood, but to focus, motivation, planning, and memory. When dopamine is suppressed significantly, the brain becomes slow, dull, unresponsive. Families sometimes describe watching someone they love go quiet and absent, assuming it is the disease progressing, not realizing it may be the medication. These drugs also carry real risks of stroke, serious cardiac events, and dangerous sedation that can lead to falls. If someone in your family is on an antipsychotic medication and it was not prescribed for a serious psychiatric condition, it is completely appropriate to ask the prescribing doctor, why was this started, and what is the plan for eventually discontinuing it? Non-medication approaches to agitation and sleep disturbance, like consistent daily routines, reduced overstimulation, addressing hidden discomfort or pain, and improving sleep environments, are often more effective and carry no cognitive cost. And here we are. Number 1. I said at the beginning that number 1 wasn't going to be a single drug, and I meant it. Number 1 is anticholinergic polypharmacy. Polypharmacy simply means taking multiple medications at the same time. Anticholinergic burden refers to the combined total weight of how many of those medications are blocking acetylcholine simultaneously. And this cumulative effect, the stacking of several individual risks into one large compounded threat, is what many researchers now consider one of the most significant and most preventable drivers of cognitive decline in older adults. Here's a real scenario. A senior takes a nightly antihistamine for sleep, an anticholinergic bladder medication every morning, and a low dose of amitriptyline for nerve pain. Each of those in isolation might cause only a subtle, barely noticeable cognitive effect, but taken together they multiply. The total burden on the brain's acetylcholine system climbs dramatically. A 2022 study published in Age and Aging followed more than 280,000 older adults and found that those with the highest anticholinergic burden had a 120% higher risk of developing dementia within 10 years, more than double the risk. And the vast majority of those individuals had no idea the medications they were taking were anticholinergic. Nobody had explained it to them. When acetylcholine gets blocked from multiple angles at once, the brain doesn't just slow down temporarily. Neurons that aren't being stimulated begin to weaken. Neural connections shrink from disuse. The brain settles into a low-powered state that, on standard cognitive testing, can look almost identical to Alzheimer's disease. But here is what I want you to hold on to as the most important thing I say today. Drug-induced cognitive decline is often reversible. When the burden is identified early and reduced carefully, many people see real improvements in memory, clarity, and mental energy within weeks to months. The brain is far more resilient than we give it credit for, but it needs the obstacles removed. The most practical step you can take is to ask for a comprehensive medication review. Bring every prescription, every over-the-counter pill, and every supplement to one appointment and ask your doctor or pharmacist to assess the total anticholinergic load. There are validated scoring tools like the Anticholinergic Cognitive Burden Scale that make this calculation straightforward. Once the problem medications are identified, a thoughtful plan can be made. Tapering what isn't necessary. Switching to safer alternatives. Giving the brain the space to recover. This is the most preventable threat to the aging mind, which is exactly why it sits at number 1. Let's bring this all together. We covered 9 medications and one systemic problem that ties them all together. Diphenhydramine, the over-the-counter antihistamine that blocks acetylcholine more than most people realize. Proton pump inhibitors that deplete B12 and other nutrients critical for brain function over time. Oxybutynin and other anticholinergic bladder drugs that cross directly into brain tissue. Statins, particularly the ones that penetrate the blood-brain barrier most easily. Benzodiazepines, which suppress the brain's adaptive capacity over months and years. Amitriptyline, one of the most potent anticholinergic drugs still in wide use. Paroxetine, the outlier within the SSRI family that carries a unique cognitive risk. Antipsychotics, powerful drugs being used off-label in settings and situations far beyond their original purpose. And anticholinergic polypharmacy, the combination effect that multiplies individual risks into something far more dangerous. The common thread running through nearly all of them is the acetylcholine system. That one brain chemical, when blocked consistently over time, puts the aging brain at serious risk. And the solution, in nearly every case, is not resignation. It's an informed conversation. I want to leave you with something that I believe deeply. The brain has an extraordinary capacity to recover when the right conditions are restored. Cognitive decline that has been driven by medication, especially when caught before it becomes severe, is one of the most treatable problems in all of medicine. The research supports this. The clinical experience supports this. But recovery starts with awareness. And that's what today was about. If any of what we covered today applies to you or someone you love, please take it seriously. Not with fear, but with the kind of calm, informed resolve that leads to real action. Write down the medications, make the appointment, ask the question. Your mind is worth protecting, and you have more power to protect it than anyone may have told you. If this video has been useful to you today, I would really appreciate it if you'd hit the like button before you go. It genuinely helps this content reach more people who need to hear it. If you haven't subscribed to this channel yet, please do. We cover practical, evidence-based health information for adults who want to take their well-being seriously, and there is a lot more coming. Drop a comment below and let me know. Did any of these 9 surprise you? Are any of them something you or someone in your family is currently taking? I read the comments and they matter. And share this one. Truly. If someone you know is over 60 and taking multiple medications, this is the kind of information that can change the direction of their health. Share it with them. Thank you for spending this time here with me. I'll see you in the next video. Take care of yourselves.